overview of the human resource for health crisis in Africa. I'm not very sure what I can do within 10 minutes, but I tried as much as possible to constrain myself just to give us, the basic overview of what is happening. I just want to remind us of the global inequalities that we have in health, generally. That, a woman has a 9 to 10 chances of reaching the age of 65 years in most of the high-income countries. But like in a country like in Malawi, it's like 4/10. And in Tanzania, every sixth child born, will die before the age of 5 years. But in the high-income countries, that's not the case. It's like every 167th child will die in every 5 years. So we could see the kind of inequalities. I'm sure we all know about these things, but I'm just trying to bring them into context. And I just put up that slide, just to give us a figure on the life expectancies, as it ranges from high-income countries to sub-Saharan Africa, to South Asia, to Latin America. You could see that in sub-Saharan Africa, the life expectancy is actually the lowest. And in other countries, there's always a development over age. But in Africa, it seems not to have happened. So we are still struggling between 45 and 46 life expectancy. Now, there's a global human resource challenge for health globally. We are looking at the Sudanese context, but it's not like only in Sudan. It cuts across generally, both in high-income country and very low-income country. But the issue is that in sub-Saharan Africa, the shortage is much more severe. So because, from the WHO report in 2006, the estimate came that 24% of the, globally, there's a shortage of about 4 million health workers globally. But this is much more pronounced in sub-Saharan Africa, where you have 24% of the global disease, and only 3% of the health workforce globally is in South Africa. And then in that particular report, 57 countries fall below the threshold of the density, because WHO recommended density is 2.5 health workers per 1,000 population. So in a population of 1,000 people, is expected to have 2.5 health workers. But that's not the case in 57 countries. Out of these 57 countries, 36 of them are from Africa. And it's worthy to note that this is where we have the highest burden of diseases like HIV, AIDS, tuberculosis, malaria, very high burden of communicable disease, malnutrition, and stuff. So that graph is just showing us from the expert from WHO 2006. So it's showing us the world map and where we have global shortages of health workers. And you could see that most of the shortages are actually located down there in sub-Saharan Africa. So Africa is just where you have very high number of the countries with critical shortages. That's what the darker picture is showing us. And you could see that it's all scattered around, the whole region of Africa. Also, I just do this world map, just showing us the human resource density again by region. So you could see that in Africa, the density thins out. So we are talking about just having 3% within that region. So you could see that from the world map they're showing us. Now, what are the human resource challenges that we face in Africa? Basically, what is causing this problem, as we could see, is in most African countries and in so many other countries, but generally in sub-Saharan Africa, we don't have timely data for human resource planning and management. And that just came out from the presentation we had previously. So oftentimes we are talking about migration, health workers. Some countries could not tell you how many of their health workers have migrated. They can't tell you how many are working currently, how many are in this, within the civil service, how many are in the non-governmental organizations or faith-based organizations, how many are within the rural area and outside the rural area. We don't have that figure. And because we don't have that figure, we don't have good human resource planning and management. And without that, we always have this kind of issue in terms of human resource for health. Now, also, there's a poor distribution of healthcare workers, healthcare providers in most sub-Saharan Africa. So you find out that, from NUHA studies, when we ask them, where are you going back to? Everybody wants to go back to Khartoum. Everybody wants to be in the urban areas against the rural areas. So that distribution is very poor and is not adequately managed in most African countries. Also, there's an underinvestment in pre-service education and in-service training. That might not be very peculiar with Sudan, because I'm meant to understand that Sudan actually trains one of the highest number in terms of number of doctors in Africa. And I think that might be one of the challenges also, that we have to look into in terms of Sudan. But in most African countries, there's an underinvestment in pre-service education for African countries. Of course, we always talk about work environment that has been unsatisfactory, most of the research that we've done, in the Center for Global Health, I'm sure Rari can testify to that, also in RCSI and various places, points back to this work environment, contributing to low morale and productivity of health workers. And definitely there's unrealistic workloads, especially in areas where you have very high burden of HIV/AIDS. You realize that health workers are actually overburdened, or even when you don't have that high volume of HIV/AIDS and you have very low number of health workers. So one particular health worker, I remember, like in a research we did in Malawi, a health worker, a nurse that is not fully trained, is an enrolled nurse. So he's not trained as a highly qualified nurse. But in a night duty, that particular nurse on her own is managing 3 wards. So sometimes she's cut across, which ward do I manage and which one don't I manage? Where am I critically needed? So there's actually overwork, and then most of the time also you find people that are practicing above their scope. So people are asked to do what they are not ordinarily trained to do. So they are practicing above the scope of what they are doing, and that brings about, low morale. And of course, health worker retention rates. We've not had adequate modalities to retain our health workers. And there's also mismatches between available health workers and competencies and those need to meet the national health objectives. So, and this brings us back to the issues around planning. So when there's no adequate planning, no adequate management, so this mismatch occurs. So there's national health objectives, and we have not adequately planned what we want to use to achieve our national health objectives. So that is another thing that is coming up. And of course, there's a lack of professional human resource managers and organizational leadership. So that is very much lacking in most sub-Saharan African countries. So the human resource managers are lacking. Oftentimes you can find not that they are not managers on place, but from various studies we have done, the managers are there, but they are not trained to be managers. So they don't have that leadership quality to be able to manage other health workers they are managing. They just rose from the rank, and they see themselves as human resource managers, but they are not making, good decisions. And like I said, that brings us to the weak human resource management systems. So we have, most of the time, the systems are very weak in terms of recruitment, hiring, deployment, performance management, and supervision. That's actually really lacking. Most of the time, the issue of supervision is one thing that comes up regularly and is very important, because you find, in most sub-Saharan Africa, most people are being supervised with a checklist. So somebody comes with a checklist and he's ticking, what you're doing and what you're not doing. But that's not what's supposed to be. There's no feedback mechanism and everything. And most of the time, promotion is not based on their performance. So the performance management is not adequate. So, and of course, the threat posed by HIV/AIDS, like I said, in some of the sub-Saharan Africa, where the issue of HIV/AIDS is there, and it requires much more care, much more work from the health workers. So that's another thing. Now, I just put this work from a joint learning initiative just to show us that, in terms of mortality, on the 5 mortality and infant mortality, that the less the human resource for health, the less the density of the human resource for health, the higher the infant mortality. So when you have the lower human resource for health, the infant and child mortality tends to go up. So actually, the human resource for health is adequately very important. Like I say all the time, that is what glues the health system together. Now, when we look at the health human resource density by region, we could see from what is happening there, sub-Saharan Africa is like 0.8 per 1,000 population if we put it together. While in places like Asia, you have up to 2.3. And in places like Europe, where we are now, you have about, more than 9 per 1,000. Now, if you look at that diagram that I have there, or that short graph, the health personnel per 100,000 population. So I'm looking at it in the terms of the African countries now. So if you look at the physicians' rates, we have just 15.5 in average. But in other high-income countries, about 311. And if you look at the nurses too, it's just about 73, as against 700 and something. So what we have in Africa is like 10% of what other countries have. So these are just some figures, just to expatiate on what we are talking about. That 10 of the 45 African countries have doctor of population ratios that are less than 5 to 100,000. And the population is not, the shortage is not limited to doctors alone, but it cuts across other health workers, nurses, other allied health professionals, which I think in most countries are even worse than the doctor issue. Because, doctors are actually being trained, but oftentimes, like I said, we don't know what we need to meet our health workforce. So in some cases, we might actually be needing not to train much more medical doctors, but to train more allied health workers or more nurses, as the case may be. But we don't have all those documents and data to help us that. And I just put that beyond the national level shortages, of course, there are shortages across the country. So apart from having it nationally, within the country, you find out that there are major shortages. So even in countries where you have enough human resource for health, enough medical doctors within that country, most of them are located in the city. But when you get to the rural areas, there's a very bad maldistribution. So I just gave some few examples there, that 50% of physicians in Senegal and Ghana and in Guinea, these are small countries, are actually located in the city, where less than 20% of the population lives. And in Chad, it's the same. In the cities, you have about 71,000 physicians, but when you get to the rural areas, you have just about two physicians per 100,000 population. So it just doesn't happen nationally. It also cuts across, within the regions. Now, I wouldn't really go into details here because I was just given 10 minutes to make this presentation. So I just tried to bring, I think this is one of my last slides. So what I just did is just to remind us of the factors that are contributing to this human resource for health crisis. Of course, we have the economic reform process. And a typical example I always use there was the SAP and what it did to a country like Cameroon. But I think if we look at other countries, country case studies, we'll find out that it's the same thing in other countries. Also, government policies, like I pointed out earlier, governments were not making adequate policies, as it relates to their human resource for health. Sometimes they were not training medical doctors as the population was increasing. They were not looking at that. So there are so many policies that government embarked on that wasn't feasible or that wasn't to the advantage of the human resource for health workers. So that is what contributed, to this human resource health for crisis. And of course, HIV/AIDS, like I mentioned earlier, it was a major contributing factor. Brings about loss in terms of death of health workers themselves, and also a high burden workload on the health workers. And definitely, where we are narrowing ourselves sort of, to the researches we've looked at or the earlier presentations we had, issues around migration. Okay, so the health workers are migrating. And I wouldn't go into those details. Nuha mentioned to us about the pull and the push factors. But I just put the graph there just to give us an instance of, the share of foreign trained doctors. This is available online. Foreign trained nurses that are in selected OECD countries in 2008, or the latest year available. So you could see, country like Ireland, I'm sure Rory will talk more on this, has like, about for almost 50% of their nurses are from outside Ireland. And also it's the same with the medical doctors. So you could see that range of migration. So there's an attraction, but we wouldn't go into all those details because I just had 10 minutes to do this presentation. Now, I just wanted to bring this into context, in terms of what is the loss or what is the gain, because it's been argued that the human resource for health crisis is actually a loss to a particular people and a gain to a particular region. So what the UN Conference on Trade and Development says that for each professional aged between 25 years and 35 years that has left or that has migrated, the country has lost about $184,000 on that particular person. So that's what the argument is. But we also think about the issues around remittance, that the countries are also gaining. They are remitting money back. But, I just want to put that in context. I know that several countries, like following up from his presentation, I have slides, studies of what so many countries have done to improve their human resource for health. But the thing is that there are so many solutions. So many people have tried diverse solutions, but there have not been any result that has been tangible in all the solutions. Some people have talked about, bonding the health workers, making them to, holding on to their certificate, doing so much. But they've been myriad of examples. But, in terms of solutions or in terms of the results that are actually been achieved, we could not really tell this is what the outcome of, most of these examples. So I think I'll just end this presentation here. Thank you very much.